I'm David Adams. It's my great pleasure to welcome you to the 5th ATS Mitral Conclave.
I'm Dr. Randy Martin. I'm pleased to be joined by a colleague of mine, Dr. Fred Milla. Fred, good to see you.
Thank you for having me.
So, Fred, 9 years ago, you finished your training at Mount Sinai, and now you're in Atlanta doing a fabulous job. Tell me what, as a surgeon who was trained and then is now experienced in practice, what's the value of the mitral conclave to you?
I think that in clinical practice, you tend to learn a lot of pearls just in training,
right.
And you develop them as a surgeon. But coming to a meeting like this, where you can interact, speak to, and really engage the giants of mitral surgery, I feel like there's just so much more I need to learn still. Despite having a busy practice in mitral disease, despite feeling like I'm making progress and getting better results over time, there's always room for growth, and I think that's the important thing to learn here.
Yeah, and obviously I'm not a surgeon, but it's really invigorating to listen and see the discussion. We'll come back to that in just a second, but tell me some things that you've learned or have reinforced your practice, what you're doing, or some new things you've learned.
Surprisingly, some of the simple things, appendage closure. It's a very important topic,
sure.
And I think one that in an open surgical procedure we tend to manage very easily.
Right.
But when you're talking about more minimally invasive approaches, how do you address the appendage? For example, a patient with atrial fibrillation who you're doing an isolated mitral procedure on, we're realizing that the surgical closures from the inside aren't as effective as external closures.
Right.
So how do you approach that from a side incision? And should the side incision be the appropriate surgery in that case?
Cool.
Should you go back to a sternotomy and then apply a device on the outside of the appendage? So just something very simple as an appendage within your practice. Now I'm having to rethink that and change that approach.
It's fabulous. The interaction that as I said, watching the discussion here is really, to me, having been around these surgeons for years, is really still very invigorating.
Mm-hmm.
It must be to you to see the exchange of ideas and to see, David Adams, Tyrone David, Manuel and Tunes, all these guys talking through cases.
To get the history of how we got to where we are right now is I think, amazing. And then learning about all the new technologies coming up the road. They're both scary and exciting, but with that comes change and positive growth. So that's been, I think, a valuable experience here at the meeting.
You obviously were trained and done a fabulous job with traditional mitral valve surgery. I don't mean only sternotomy, but you're doing some new approaches and that stuff, and you've done some stuff with the neocord, with the chordal techniques. How do you see the transcatheter therapies impacting your practice in the future?
I think the transapical approach is something unique still to surgeons.
Right.
And I think I've been working closer with my cardiology colleagues on how to translate that information to now applying that same type of technology like neocords to a transcatheter transseptal approach. I think that as surgeons we can offer a lot in advancing that technology, because we have very intimate knowledge of adjustments and chordal length, whereas it's not been the practice of cardiology to do that. So I think we play a very vital role in getting that to work and advance.
That's cool. I think that if you looked 10 years out, how do you think your practice is going to look for mitral valve therapies? Just your ideas.
Right. I think that we're certainly going to be required to offer just excellent surgery when we're doing mitral procedures. All of the things we talk about, high rates of repair, low recurrence rates, low mortality. That will always be there. And how we apply these technologies and being thoughtful during that process, I think, is going to be how we're going to change the field. And I appreciate that we're looking at a longer runway, as was described, in the mitral space as opposed to the aortic space, because I think it's going to really take some thoughtful planning and timing to keep those results and keep that our expectations as they should.
Good, super. Well, thank you very much. Good to see you again.
Thank you.
We worked closely
Always a
together for
pleasure.
years, and I enjoyed it. Thanks for it.
I really appreciate all the support you've given me in the
Thank you.
past.
Thank you.
Thank you.
It's been a mutual admiration
Yeah.
society, and thank you all for joining us.